Webinar on how to capture and use basic social, development, and health data with communities. I am Tyler Best, a program officer with the Johns Hopkins Center for Communication Programs and the Springboard Community Manager. Today's webinar is being hosted by Springboard. Springboard is an activity of the Breakthrough Action Project, a cooperative agreement funded by the United States Agency for International Development to lead their social and behavior change programming around the world. Breakthrough Action ignites collective action and encourages people to adopt healthier behaviors, from using modern contraceptive methods and sleeping under bed nets to being tested for HIV, by forging, testing, and scaling up new and hybrid approaches to social and behavior change. Before diving into today's topic, a few housekeeping items. There's a chat box in the lower right corner of the screen, so please introduce yourself. If you don't quite catch something, that's okay. This webinar is being recorded, and we will make the recording and presentation slides available shortly after the webinar. This webinar will have a presentation section, followed by a question, answer, and discussion section. During the question and discussion portion, you will have the opportunity to ask questions and share your experiences or thoughts verbally. To let the moderator know that you want to ask a question or share a thought, please use the raise hand function. The moderator will then invite you by name to speak. To raise your hand, click on the Participants tab. In the Participants box, you will see a raise hand icon that you should click. Finally, if you're looking for more information on today's topic, please be sure to take a look at the trending topic, which has a link of helpful resources. Improving the health and related services that are provided at the community level requires strengthening the monitoring and evaluation systems that are applied at the level. Over the years, Save the Children has worked with many communities to strengthen their capacity in typical M&E functions, such as measuring, recording, collecting, processing, and communicating information. In our webinar today, Dr. Lynette Golding, Gill, and Heather Gardner of Save the Children will discuss how to capture and use data with communities. Dr. Lynette Golding is an advisor of nutrition and social and behavior change communication at Save the Children. Gill is a senior advisor of community and social change at Save the Children. And Heather Gardner is a senior specialist in monitoring and evaluation at Save the Children. I will now turn over to Lynette.
Hello, everyone. I'm Lynette Golding with Save the Children. Thank you for joining the webinar. We're excited to share some common approaches to community monitoring and evaluation with you. We're going to highlight some lessons learned and also go over some of the common pitfalls. Over the years, Save the Children has worked to institutionalize systematic community engagement at multiple levels, through linking community health workers with service delivery, to supporting community self-organization and collective action, and also supporting household behavior change. We believe that communities matter. Communities make it possible for us to pool the strengths we have as individual human beings to achieve things that we could not do alone. They enable us to collectively mobilize our individual powers to face challenges with greater possibility. At this point in our history, humanity faces significant and urgent choices and decisions. When ordinary people are able to create, link, and strengthen their own communities, and through them have a voice and act out what they think and feel and want, they acquire more power over the choices and decisions that affect their lives. For those unnumbered millions living in poverty and without basic rights, community engagement makes a different future possible. A former community health and development professor of mine often used to say, "See what is there, support what is possible." That quote is fitting for today's webinar. Increasingly, there's a recognition of the role communities can and should play in using their own data to make decisions, to plan and to implement, and to improve community interventions. Nevertheless, we all have probably experienced token involvement of local people where representatives are chosen but have no real input or power, or where outsiders decide on the agenda and direct the process. But removing restrictions to data access really democratizes and facilitates its use. When bottlenecks to data access are removed, communities can use their data to improve the quality and coverage of services, decide which activities to plan and prioritize, and/or determine how to spend or advocate for resources. Like that old saying, give a man a fish and you'll feed him for a day. Teach a man to fish and you fed him for a lifetime. Only we want to take it a bit further and teach people how to organize so that they can fashion their own solutions. Next, we're going to hear from Gill, who will share a few examples of how she and others have captured and used basic social development and health data with communities. And then I'll be back to share some common approaches to community monitoring and evaluation.
Hello. I'm hoping the story you just heard may have sparked some questions, such as, who owns community health data? How can it be used by communities? And how can health data improve community action to improve their own health? Hi, I'm Gill, Senior Advisor for Community and Social Change for Save the Children. I'll now be sharing with you 3 case studies on how communities have used health data to improve their own health issues. We'll be hearing from case studies from Bolivia, Ghana, and Mozambique. Let's get started. Our first case study is set in Bolivia. The project was called Sistema Epidemiológico Comunitario Integral. That meant actually Community Health Monitoring Systems. It was called CESI. And I chose this case study because it was one of the initial efforts to actually help communities use health data to improve their own health outcomes. The project was a joint partnership between Save the Children and Johns Hopkins University. Why was it developed? It was developed because there was an underutilization of health services in the rural areas of Bolivia. There was a lack of community participation in planning for health activities, and there was limited communication and dialogue between health providers and users. It was implemented in the rural highlands of Bolivia in Oruro in 130 communities, about 65,000 people. It sought to improve health behaviors related to the non-use of services such as ANC, safe deliveries, and care seeking for childhood illnesses. There was eventually uptake by Plan International and by other organizations in Bolivia. So what was the CESI process? The process focused on simple user-friendly tools that communities could use to actually visualize the health issues in their own communities. So you can see the tool on the right-hand side. This is one of the tools where there were picture graphs related to the particular health indicators that were being tracked. So the process involved community health promoters collecting monthly health data from families on breastfeeding, complementary feeding, maternal and newborn mortality, etc. Service providers also collected service utilization data. And then at the end of the month, together they consolidated their data to be placed on the bulletin board. The bulletin board, as I mentioned before, was colorful and user-friendly in order for it to be shared with communities and to be understood. The diagrams were also pre-tested before being developed. And here, community members reviewed and analyzed data according to severity and frequency. And this was done on a monthly basis. You can see on the right, as it was consolidated, the colors red, yellow, and green were used to distinguish on severity and frequency. So, and it was the colors of the Bolivian flag as well. Red being the most severe and or most frequently seen as the issue or a problem. Yellow, moderate, green, that they may be making progress. The communities were able to track their progress over time. Together, They set priorities based on this data. So if you had high incidences of newborn mortality, there on the red side of the flag, communities would then go on to make action plans on strategies that they could use to address it. The bottom line being, without that actual data visualizations, communities would have not known really the frequency or severity in their own communities. So, did it work? Well, yes, we saw changes on individual level in practices on childcare, nutrition, on care seeking and hygiene. There were changes on collective community action and changes in the power relationship and advocacy between communities and government structures. For example, we did see an increase in exclusive breastfeeding 1 hour postpartum, and this was significant change. We saw a change in complementary feeding, putting oil in children's food. There was also community action that was realized. So, for example, they were able to agree with health providers on a schedule for child growth monitoring and vaccination. There was resource mobilization at the kindergarten for improved school feeding. Communities were mobilized, including men, to construct a health post using local materials. And there was an increase by communities of demand for health data and information from service providers. On an advocacy level, communities requested support from the mayor to make a greenhouse for food production, and that municipal funds were paid to the hospital as per agreement. There was a request to the district health director to change an unpopular physician who was yelling at women during at the delivery and prenatal checkups. They obliged the health staff to come once a month to the community for their home-based care and vaccination and growth monitoring. There was also some qualitative results around communities having a sense of greater self-reliance and responsibility for their own community health. And community health indicators continued to improve after the end of the project, including improved skilled attendance, skilled birth attendance, skilled deliveries, What CESI didn't do is, and this is important, is it didn't ask communities to do the work of government. It didn't monitor the health indicators from the project or from the donor. It did not give precise epidemiological data, and it wasn't meant to solve all health problems. What did it cost? Well, there was the time of the health promoters to collect, consolidate, and present data. Community members met monthly, so there was also time needed for them to devote to community action and volunteerism. And we had NGO staff to facilitate the initial meetings. The materials were a flannelgraph and the picture cards and markers and flip chart paper. Some questions that we were left with after CESI was, what type of data actually motivates or mobilizes communities? Is it morbidity data and comparison? Are case histories more impactful? Does health service data fuel conflict, meaning the production of extra data? Will that create a conflict with the service data that's being developed through the health system? And does monitoring this practice make it all more difficult for everyone? But all in all, communities really felt that they had benefited from using health data to analyze the issues in their own community and create an action plan on that data. Let's now look at our second case study. This case study is from Ghana. It is called the Community Health Decision Systems. It was a pilot project, again initiated by Save the Children and our partnership with Johns Hopkins University Center for Communication Programs. CDS, as it was called, was designed to improve access by communities to health data in order for them to know their own health status. Community members worked with community health officers to gather and use health information, analyze this information, make decisions, make action plans, and monitor their action plans going forward. It was implemented in 2 pilot districts in the central region and in the eastern region, in 13 communities in the central region and 14 communities in the eastern region of Ghana. Startup activities were very important in order to integrate this into health systems and work hand in hand with government partners. So there was consultation meetings with the regional health management team, district health management teams, district authorities. There was an orientation process. There was formative research to understand what are the health issues that should be addressed by the CDS system. And there was a launch that involved all stakeholders, including village chiefs, elders, and community members in general. So which indicators did CDS decide to choose on? Well, in this case, they focused on the incidence of malaria, the use of ITNs, treated ITNs, the sanitation status in communities, regular attendance of pregnant women to antenatal care, safe and skilled deliveries, and deaths through preventable illnesses amongst children. There was capacity building process that was put in place that trained 2 staff from the government health planning unit, 9 from the district health management team, and 6 from the regional health management team. 28 community health officers and their supervisors were trained, and 188 community health team members. This included community health committees. This is what the bulletin board looked like in Ghana. That's the village chief standing there on the right-hand side. This is a closer view of the bulletin board. It was generic. It was called Our Community's Health. On the left was a space for the health indicator card, which I will share with you just now, and it was tracked monthly. The total population for that community was written on the top. This was an actual chalkboard, so children under 5, and the breakdown, and it was disaggregated by gender. I'm going to share with you on slide number 8 some of the health information cards. This is the health information card for sleeping under an ITN, and a separate card to the right was for fever. This was for correct and timely treatment of malaria, for measles and breathing difficulties, and these cards would be hung onto the bulletin board. Diarrhea, as well as the wash facilities. These were 2 separate cards. Slide number 12 was delivery by a skilled trained birth attendant. The tools required for CDS, well, there were 150 community health bulletin boards produced. They were big, just chalkboards, like a school chalkboard. There were 10,000 health information cards printed with 13 separate images based on the health indicators that were being tracked. There was community decision systems data consolidation forms printed, and we used the community action cycle, which was a process for the community health teams to get organized and to meet monthly and to analyze and to make plans around this health data. Data collection process was the following. Community health volunteers and traditional health providers collected data on the key behaviors at the community level from families. Community health officers kept records of service utilization and home visits and disaggregated it by the number of communities that they were covering. And on a monthly basis, this data was consolidated together. So community health volunteers and the community health officers consolidated the data. Community health volunteers then assisted the community health committees using the simple bulletin board and the health cards to place this information on the community health bulletin boards. There's the village chief who kept the health bulletin board in his home until it was time to bring it out to the community and for the community to be able to share and look at this health data and analyze what was happening in their own communities. Then the community health committees would set priorities based on the bulletin board and on these discussions and integrate these into their action plans. And community health committees monitored their progress every month and adjusted their strategies. And you can see that there's writing on that community health bulletin board according to those health indicators. So this was the health management. There was monthly data collection, and then there was quarterly feedback to communities and discussion and interpretation of the data using the health bulletin boards and a prioritization or reprioritization of health issues. And action plans were adjusted accordingly. There was supervision from the regional health management team to the district health management team, and also at the sub-district level. And this is the entire community decision-making CDS system. So on the left, you had who made up the community health team and their roles. The community action cycle was in the middle, so it was around how the community health committee got organized and was able to use and process this data. And those are some of the community groups that were also involved on those quarterly feedback of the community health bulletin boards. Some preliminary outputs included, there was a sustained demand for treated ITNs. Some communities established a credit scheme to facilitate the purchase of ITNs. The community volunteers were sustained to maintain wash facilities. There was a creation of community refuse disposal sites. And there was an increase in health education sessions on home-based care and cases and treatment of malaria. So now let's move on to our last case study. This case study is set in Mozambique, and it's around the use of community scorecards and that type of data visualization for the improvement of quality service delivery. On the left, you'll see this was a project implemented by the Maternal and Child Survival Program. It was set in Mozambique. On the left, the government of Mozambique is taking up this initiative as far as its quality improvement processes. Slide number 2, what is the scorecard? Well, the scorecard is a participatory tool guided by the Save the Children Partnership Defined Quality process, which is a process to help communities explore, plan, and monitor service quality along with health providers. This particular initiative in Mozambique was implemented through the government-mandated, facility-based co-management and humanization committees. And the purpose was to increase community participation and transparency with health providers on the improvement in quality services. It was implemented in 2 provinces in 82 health facilities. It was in Nampula province in 53 health facilities and in Sofala province in 29 health facilities. There were phases of the partnership-defined quality approach. This is slide number 3. And the implementation of the scorecard. So the first phase was actually getting communities and health facilities oriented to the partnership-defined quality approach and to what the scorecard process was going to look like. And the second phase, problems and health service quality was identified at the community level as well as the health facility level by health providers. In the third phase, the health providers and community members came together and prioritized what the health quality improvements priorities would be, and jointly with the community, the co-management and humanization committees developed an action plan. In the last phase, that action plan was implemented in cooperation with the community health committees and the facility-based committees for the humanization and quality improvement of services committees. And the scorecard was used to track progress. Initially, and I'm sorry you can't see this very closely, the humanization and co-management committees at the facility level prioritized which quality indicators to track. And there are just some examples on the left. So together, through the partnership defined quality process, they prioritized? Was it that there was lack of a waiting home, a maternity waiting home? Or were there insufficient staff at the maternity, at the health facility? Or was there a lack of medicine? Or was there poor treatment of clients from an interpersonal level when they came in? So they set priorities and the reasons why. Then the scorecard was developed from that. So if it was around the waiting home or the maternity center, that would be there on the left. And then it was on a Likert scale, 1 being very poor, meaning it maybe didn't exist. 2 was that it existed but perhaps needed to be upgraded. And 3, muito bem, was that it was really something that they valued and the quality was great. So the same was with the number of personnel at the health facility. They would rate it 1, 2, and 3. The availability of medicines, 1, 2, and 3. In this scorecard process in Mozambique, the indicators were generated together from between the community and the health facilities through a partnership defined quality process. The results, well, there were 72% of the health facilities ended up, and this is the quality improvement and humanization committees, developed a quality improvement action plan. Areas of focus included attendance and punctuality of health service providers were improved. Humanization of care was improved. The management of essential medicines was improved. And the illegal charging for health service was also being addressed. Here is the issues that were addressed according to the health facilities. So community burst, meaning to improved, skilled, and safe delivery at the health facility was being addressed. Illegal charges were being addressed. The sale of illegal sale of drugs at local fairs was being addressed. The humanization of care at the antenatal clinics during maternity stays was being addressed. Cleanliness at the health facilities was so it really depended on the issues between communities and the health facilities on which indicators were going to be addressed and what was going to be placed on that scorecard. In the end, we were seeing an increase in first and fourth antenatal care visits in at least 6 of the 18 health facilities. There was an increase in family planning uptake in at least 5 of the health facilities. There was an increase in demand for consultations for healthy child in at least 12 of the health facilities, and we saw this increasing after the end of the project. I'm going to stop there. There's lots of benefits to the partnership defined quality and the use of scorecarding in Mozambique. Thank you for listening to these 3 case studies. We hope you enjoyed them. And now we're going to continue on with the rest of our presentation.
Thanks for all the examples, Gail. So for this next presentation, I'm going to highlight information found in this recent publication by the Maternal and Child Survival Project, also known as MCSP. This resource package can be downloaded from the MCSP website and walks users through how to engage data users and producers, how to conduct assessments for improving data use at the community level, how to build and strengthen core competencies for data use, and how to support communities to translate data into action, and also ensure that systems and policies are in place to support sustained data use. This resource package was informed by resources from Measure Evaluation and other sources, including non-governmental organization tools. It's important to note that when we're referring to community-level data, we mean that those data that are the sum of individual data. We are not referring to individual-level data, which should be protected in private. Also, we mean that the use of data by community actors. Here, community is defined as a collection of households in a specific geographic locale. In some places, the community may be the first level political organization or the first level at which health services are delivered. For example, data collected by community health workers or volunteers attached to health facilities and serving multiple communities would fall under this definition. Actually, there are quite a few potential community level actors that can be involved in data collection and use. Anything from community members to members of community-based organizations and civil society organizations. So to better incorporate participation in monitoring evaluation, several methods and approaches can be used, ranging from qualitative or quantitative to measuring how participation translates into desired outcomes, such as voice and empowerment, to adopting a participatory monitoring and evaluation approach that produces data to advocate for higher quality services and more targeted programming. Now, as I started in the beginning of this webinar, or as I said in the beginning of this webinar, global health programmers sometimes do not treat community members as equal stakeholders in knowledge generation. Hence, there are a few guiding principles that we like to work from. First, it's important to understand what kind of data community level stakeholders prioritize and what information is valuable from their perspective. Also, understanding stakeholders' motivations and needs is key to improving data use. For example, in the community scorecard approach, perception-based indicators are developed jointly with the community based on the issues raised during focus group discussions with community members. And these perception-based indicators can include things such as waiting at the health facility, the wait times, attitudes of the service providers, and health facility operating hours, all things that may be important to community members. Secondly, intensive capacity strengthening, supervision, monitoring, mentoring, and data quality checks are essential. And you really need to build in ample time and resources and continually strengthen the capacity of those people collecting and using data. Also, standard community engagement and participatory research or monitoring and evaluation approaches can be used to engage relevant community stakeholders for data use, including those community dialogues, community health committees, appreciative inquiry, and community mobilization. It's also important to use simple tools. So, for example, as Gill pointed out, community information boards can use images so that illiterate or low literacy community members can have a better idea of what is being presented. Here's how a board could look, say, in northern Nigeria. Please refer also to the resource package for other important guiding principles for stakeholder engagement. Now I want to go through like an example process that's in the package, the resource package. It highlights this process and also important questions to ask along the way. So for instance, what information do stakeholders need to make decisions related to their job functions or daily lives? Or what information do they currently have access to, and what information would they likely would they like to access? Also, how would stakeholders use this information to guide decision making or develop action plans? And where would stakeholders get relevant community health information? In what format? In what frequency would stakeholders want to analyze and interpret data with respect to any data literacy limitations? Also, what are their data information needs and what challenges do the stakeholders face? Maybe they don't know how the information they provide can contribute to program and funding decisions, or maybe there's a shortage of staff, including community volunteers. Specifically, people with data-related expertise, or maybe the people being asked to collect the data are pressed for time and feel undervalued. Now, in terms of community-based indicators, they can be used to inform accountability and policy change and feed into community-level evaluation of interventions. These indicators can also provide information on behaviors and home-based practices by community members, which may help to encourage and empower action undertaken by communities. It is also important to strengthen the community's capacity to use data. Community health workers or community volunteers or community members and/or community leaders can use tools such as registries, tracking forms, family health folders, scorecards, summary forms, all these to collect and manage data. Additionally, they can also use wall charts or graphs or data dashboards or other tools to analyze and visualize their data. Now, initially, training and ongoing supervision for data collection and management are often inadequate, so programs should strengthen training and supervision, especially data use and feedback during ongoing supervision. Heavy reporting burdens of community volunteers across programs can also affect the quality of data and community volunteer motivation, so programs should take this into consideration when deciding what data to collect and use. Also, data collected at the community level, it belongs to the community, and they have a right to the information generated. Making information accessible at the community level can inform program management, also ensure accountability. Additionally, it can help communities advocate for resources and policy decisions. Data can be shared at the community meetings, at data review meetings, or similar fora. It is recommended that these meetings culminate in an action plan developed with next steps, timelines, and names of individuals responsible for following through on the actions. The action plans developed at community level can be tracked periodically at a frequency agreed upon by community members and revised as applicable. Lastly, sound governance and support for the government is needed. National policies and strategies should provide the framework and guidance to facilitate data collection at the community level and also specify ways through which the communities can extract and act upon the data. Some countries also have policies on data transparency and accountability. So, depending on your resources, the use of geographic information systems through mobile devices by trained community volunteers can be used. Mobile options are indispensable for generating large amounts of data that can be collated and analyzed and turned into information in real time. For example, data on natural resources, demographics, water and sanitation can be generated and managed in direct collaboration with communities. It is therefore imperative to bridge that digital divide by helping community-level stakeholders build capacity for electronic data capture. That said, not all paper systems can or should be digitalized. Digitalization depends on data flow and user needs, and thus requires an understanding of the community health program or system. So let's talk about some common difficulties of community monitoring evaluation. Because just because data exists does not mean that they're used. There might be low monitoring evaluation capacity or poor data quality. Community workers might be overburdened, and there just might not be a demand for data. I like to say that people tune into WeFM. That is, what's in it for me. Community monitoring evaluation will only be consistently relevant and accurate when community members find value in the data they generate and use. Now, often cited a barrier for accessing and using data at the community level is lack of resources and harmonized tools that enable community data use. Community-level data for decision-making for local planning and management receives minimal support in many countries. This lack of support is particularly notable when considering that the people responsible for collecting data are often not salaried and do not receive regular incentives. Financial and human resources are necessary to strengthen local capacity for sustained data use at the community level. And this includes allocated funding for data collection, analysis and use, and building capacity for those efforts. Okay, so that's all for now. Be sure to look at MCSP's Supporting Communities to Use Health Data, a resource package for more detailed information. And now we'll have time for a small amount of discussion. Thanks.
Hi, everyone. Sorry, technology issues. Always a blessing and a curse. Thanks everyone for joining. I wanted to take a quick moment and introduce my colleague here, Heather Gardner. Hello, everyone. Heather has been working on community level data collection for a long time. So we were lucky that we could rope her into the room to help us with this discussion. I also wanted to take a moment to look at the poll results, and I'm wondering if we can pull those up. All right. So this was kind of a trick question, and sorry to do that to you, but we all the things that we included in this poll actually could be checked on why it's important to involve community members in monitoring community level data. We said it was multiple choice and to check all that applied, but when we were putting when we were putting the answers together, we thought you could check all of them. So it's interesting to see that there's some various answers here. And now I think, as Tyler said at the beginning, I think we have some questions already. And let me just open up my chat box. We can maybe start with those. Oh yeah, sorry. Gail's on the line too. Gail, I wanted to give you a moment if you wanted to say hi. Oh, and you have someone behind you. You want to unmute yourself, Gail?
Hi everyone.
Uh-oh, can't hear you.
Hello.
Oh, you can. Oh, okay, I just can't. Okay, gotcha. All right, sorry. Oh, technology. Okay. So Gail's actually coming to us from South Africa somewhere. Where are you at, Gail? What city are you in?
I'm in Cape Town. Hi, everyone.
Okay. All right. So we had some questions or comments from folks on the line, and someone wrote in and said, "Hello, and thank you for keeping this important theme on community involvement. Beyond HCD, I'm thinking human-centered design. Is it possible to create, with community participation, case studies on use of LLINs, long-lasting insecticide-treated nets?" Okay, the frequency of pregnant women and the rapid use of care. I think we need to innovate in community collaboration. Gail, I don't know if you want to take that on and talk a little bit about your experiences and creating kind of an enabling environment to work with communities.
Yes, and I'm hoping that means human-centered design. If you're still on the line, maybe you can type in the chat box. But yes, I mean, you know, human-centered design has has come from a number of processes over the years. Community participation, I think the question was case studies on long-lasting and the frequent. I think the question is community participation can be fostered in many, many different ways. Human-centered design, I think, is one approach. The case studies I shared were from the community action cycle approach, where we helped communities get organized around a goal or an issue. So I think what's important, and what Lynette mentioned in her part of the presentation, is the indicators need to be relevant to those communities. And can you hear me okay? Can you hear me okay? Lynette, are we okay? So whatever the indicators are that are chosen, they have to be relevant. They have to be maybe based on some epidemiology as well, in order to generate interest in the communities to continue to monitor them. I'm going to stop there.
Okay, great. Thanks, Gail. So from Ellie on the discussion forum, she asks, how do you address the problem of data unavailability that we often experience at the community level? Take that.
I'll take that. Hi again, my name is Heather Gardner, and I contributed, that is by way of reviewing, to this community data package. And with regard to lack of data lack of data, I think kind of similar to the last question, it's an opportunity for innovation. And it seems to me, again, that the key consideration here is our audience. And that is, so to speak, I'm defining the audience as our key stakeholders, the community itself, and their needs and their priorities drive the data agenda, for lack of a better word. And so if they've identified a need area where data do not exist, I think there are ways to get kind of creative. And the packet illustrates formal data sources and informal data sources. And I think one possibility would be to examine some informal data that community members have a lot of expertise just through their own observation. So I guess a part of me is saying, how can we not get too locked in to just formal data sources, but kind of think outside that box a bit and identify kind of informal strategies for garnering the information that the community wants in order to be responsive to their agenda. And I'm just thinking of observation as one method. Just by being and living in the community, I feel like there's a lot of kind of informal data collection that just happens by living there and being there. And I'll just conclude my comments because I know we have other questions. On page 9 of the package, we define formal information can be hard or paper-based or electronic forms of information, like that which is collected through the health management information system. Informal information in this maternal and child survival program resource package is defined as verbal, observational, or experiential points that are not necessarily collected through these kind of formal mechanisms, but are actually really critical for decision making and for, as it says in the package, for qualitatively understanding health outcomes of populations. So I hope that's helpful, Ellie. Thank you for that really good question on what to do with data gaps.
And Gill, I'm wondering, do you have anything to add?
I would just hope that, I think there's another question in the chat box. I don't know how we're doing on time around policy to support data use and, government level attention to community data and use. And this is such an important question. And on the case studies, I think really I think the Ghana case study, as well as the Mozambique study, and eventually the Bolivia case study, did have government partners on board. And in Mozambique, through the guide that was shown and through their new Department of Quality at the Ministry of Health, they really are trying to institutionalize the use of community data by communities themselves. And that's very exciting because it shares the fundamental right of communities to know what this data is and to foster its utilization.
Great. Yeah, to see we have another question in the chat box here. It says, and this one's from, I don't know the first name, Haruna. So let me last name, yeah. Haruna. Hi everyone. Talking about policy support to data use. I am worried about government level attention to community data and use. How best can we ensure government get more involved in community data collection and use? Are there any case studies? And Heather, I think in that document, in the guide or the resource package rather, there is some thoughts on that. Yeah.
Actually, on page 38 of the Supporting Communities to Use Health Data resource package developed by MCSP, in box 16, there's an example of policies for community level data collection and use in Liberia, which I thought was actually really interesting. And just to pull from that sort of box, in it, it delineates how the Ministry of Health in Liberia embedded the generation and utilization of reproductive, maternal, newborn, and child health data at the community level within its revised National Community Health Services Policy, as well as the Liberian Health Information System and ICT's strategic plan. The policy, objective number 5, states, developed robust community-based surveillance and information systems linked with national health monitoring, evaluation, and research systems. So it provides a policy framework for community-level data use. I would just add one thing to caution is that community health information systems, which can be national systems, also we need to ensure that those have applicability at the community level as well and not just at the national level. So I just will point you back to the resource package and to the beginnings of page 38, in which there's an entire section dedicated to policy, governance, and strategy. Thanks so much. Thank you. And I wanted to go back to one of the first questions. This one's from Vidya, and she asked us when Gail was going over the case study. She said, did they use ICT tools for sharing data with community? So Gail, do you know, I think that question was directed to you, ICT tools for sharing data.
I'm not sure if she could clarify ICT. I'm not sure if anybody in the line can help. I could make it up, but I'm not sure. It sounds like a communication tool. Vida, can you clarify? Here we go.
Yeah.
Internet and communication technology. No, I do think that I think that not at the time, but I do think it offers enormous possibilities in the future for communities to be able to, and community health volunteers, community health workers, of course, use their tablets, but communities in general to be able to have access to data in their community. The Ghana example, I just wanted to mention, they got 100% ITN utilization because they knew their denominator. They knew how many households there were. And not only were ITNs distributed, but they knew that they were being hung and they were checking if they were being used. So, you know, that kind of data, having access to that through internet and communication technology on hand, I think we can imagine how incredibly mobilizing that would be to see progress.
Great. Thank you so much, Gail. So I see we have about 2 minutes left. So maybe this is a good time just to wrap up. And I want to thank everyone at Springboard for their help to us on putting this webinar series together. This was the 4th in the series. And there is a post-webinar poll. If you could take that, that would be great. I also want to thank Gill, who has stuck with us throughout this webinar series and helped in various ways, and Heather for being here. Yeah, and it's just been a real pleasure. So let us know if you have any other questions. This, as Tyler said, this webinar will be is being recorded and will be available. Thank you so much.
Thank you. Thank you, everyone.
Great, thank you to Lynette and Gail and Heather, of course. Please log into Springboard and head over to the discussion forum to keep discussing this topic. As they said, you'll see a poll. Please answer that if you're able. And thanks once again to all of our presenters for their work and their help today, as well as all of the work they did for the previous sessions. And just as a reminder, we will follow up with a link of today's recording and presentations. Thank you very much.